Professor Yonathan Halevi. Professor Halevi. Here are some highlights from the CV of Professor Halevi. Professor Halevi is a Director General of Shaarei Tzedek Medical Center and one of its internal medicine unit. He has held a wide range of public positions, such as chairman of the Israel Transplant Center from 2000 to 2006, and a member of the executive board of Bar-Ilan University from 2004 to 2007. Professor Halevi is an associated clinical professor at the Hebrew University Hadassah Medical School, where he is a very active teacher and lecturer. Medicine, if you want to know anything about complementary and alternative medicine, he is the person you should ask. He wrote a book about it. The title of Professor Halevi's talk is Training Doctors, Special Characteristics in Medical Education. And Yonathan, you are please welcome. Thank you.
Good morning. I would like to thank the organizers for inviting me to this lecture. It's a pleasure being among teachers and educators, and I have some free associations from the excellent lecture of Professor Ariav, which I probably will share with you in the next few minutes. But just as an introductory remark, in order to prove to you that you are more important than us, I would like to quote some paper that was published by the WHO, by the World Health Organization, many years ago, that set the determinants, quantitative determinants of health. What determines the health of a person? So they give their 20% to genes. They give their another 20% to the socioeconomic status. Our sages said, Ani chashuv kemet, a poor man is considered dead. Our sages would never say such a thing unless they understood that a lower socioeconomic class determines a lower level of health, and we know it today in modern medicine as well. So 20% of the determinants of the health of a person are genes, 20% are socioeconomic class. Another 20% is healthy lifestyle. Now, we physicians, to a certain extent, but to a very small extent, are responsible for healthy lifestyle. You as educators have more responsibility to educate the public towards healthy lifestyle. Well, healthy lifestyle means avoidance of smoking, avoidance of drugs, avoiding of alcohol, and I guess that these perceptions and decisions of youth, if to live all through their life healthy lifestyle or not, are determined more by education and educators than by physicians. The same WHO report gives only 10% to all this modern medicine with the intensive care units. And with all the innovations in medicine, they determine only 10% of the health of a person, because we come too late. When the patient is already sick, we put not enough emphasis on preventive medicine that is famous for being the most effective medicine. So in medical history, we did a lot in order to promote preventive medicine. If you take vaccines were the major revolution in modern medicine. But ultra-modern medicine puts emphasis on curative and palliative care and not on preventive care. And with this, we determine only 10% of the health of the person. So when we talk about education and medicine, you are more important than us. Another merge or overlap, not merge, but overlap between education and medicine, where you take priority. Professor Ariav mentioned the Flexner report. You mentioned very briefly the date of the Flexner report. It's 103 years ago, 1910. Flexner was a teacher and an owner of a school, not a medical school. He was not a physician. And I can tell you that the reform that was brought about by the Flexner report is actually active till today. Your second challenge, Professor Ariav, was that Teacher education is a profession in transition. Education, medical education is all the time reforming itself, but not major reforms. The major reform occurred 103 years ago in 1910 when Flexner, the teacher, reviewed 165 then medical schools in the US and found most of them to be totally inadequate, teaching totally non-evidence medicine, and maybe we'll get back to it. I was presented as an expert on alternative, complementary and alternative medicine. I am not at all. I wrote a book about the scientific facts about complementary and alternative medicine. But we are closing a circle today because most medical schools today do not teach alternative medicine, but they teach about alternative medicine because the public, and that ignites the imagination. We physicians serve the public today really with so innovative diagnostic and therapeutic modalities, and still, and this is much food for thought for us, the medical community, and still complementary and alternative medicine that can be united under the theme of non-evidence medicine is prevailing and popular more than ever in the past, so much so that every modern medical school finds it necessary to educate physicians to know about alternative medicine, otherwise their dialogue with the patient will be severely affected. So this is the fact that Flexner brought the reform in 1910 and actually introduced modern education that I will speak about in the next 20 minutes, and his reform actually exists till today. In the next 2 decades after 1910, the 165 medical schools reduced to 65 medical schools, and actually the basic curriculum of a medical school today did not change since 1910. Yes, we are in the digital area. Yes, yes, when I do rounds today, when I did rounds 35 years ago, and we encounter the patient that poses a constellation of symptoms that we could not decipher and understand, I would send one of the residents, well, 35 years ago I was a resident, so I would go to the library. There was a big room there full with books called Index Medicus. It would take me 2 days to see if a constellation or a combination of symptoms can be diagnosed as one disease. Today, the medical students, when I do the rounds, on his cellular phone, corrects me when I talk nonsense. He just looks it up, he Googles it up, even Wikipedia is good enough today, and he says, this is not true, Professor. So in this respect, there is a major reform. But in the construction of medical education, there is not much reform since the Flexner report. Another association from your talk, Professor Ariav, is about expectations. Yes, society expects you to correct everything. But society expects from us absolute health. You want a proof to it? When I have a running nose, everybody tells me a physician cannot take care of his own running nose? So the expectations are absolute. I mean, a patient who enters the emergency room expects to be healthy, preferably after 60 seconds since he entered the emergency room. So the problem of discrepancy between expectation and the actual performance that we can satisfy the public with, the discrepancy is as big as the discrepancy between the expectations of society from educators and from teacher educators and reality. So let's talk about medical education after mentioning Flexner as the great reformator. So in the Western world, there are 2 types of medical schools. One type is based on a 4-year program, the other type is based on a 6-year program. In a 4-year program, you expect a bachelor degree from college. This is the American system. The European system is based on a straight university MD 6-year program, most of the times in most countries also 1 year of internship. In Israel, we have today 5 medical schools. 2 of them have both programs, a 4-year program and a 6-year program, and actually medical education in Israel is in transition from the classical European system of straight university, straight MD in 6 years, to the American system of getting a bachelor degree and then have a 4-year medical education. The number of years is not so important. It's important what we expect from the students. And here we have a problem, similar problems that you mentioned, Professor Ariel. Actually, listening to you, I was amazed to see so many similarities between teachers' education in particular and education at large to medical education and educating physicians. So why is this difference between 6 and 4? Because everybody copes with the problem how to prepare a medical student to the clinical years. I will get to it in a minute, but I would like to start by saying, and I think as much as in your profession, selecting the right candidates to be teachers will dictate to a large extent the level of teaching. Sorting medical students in a proper way, and I would say at the outset, nobody in the world found the proper way yet. Sorting them right will guarantee the level of the profession. But there is one difference. If I leave a minute teacher education and go to education at large, you have to teach every child in society. We don't have to accept to medical school to raise physicians out of the wide public and to accept everybody who comes. And this is our advantage. We can sort the students, and for generations, we sorted them based on scholastic achievements. And the scholastic achievements dominated. In Israel, we have the psychometric test, somewhat similar to the MCAT. 800 points is the maximum. I can tell you that to the 5 medical schools in Israel today, if you have less than 740, your chance to be admitted are close to 0. If the final exam in high school is less than 108, 109, ממוצע משוקלל, you have no chance to get to medical school. So there is a basic prerequisite of very high scholastic achievements. Actually, you have to be in the upper 1%, some say even 1 promille, but I believe upper 1% of your class in high school and your performance in the psychometric test in order even to be screened initially. That's when medical schools differ in sorting of patients. We all understand that to be a scholar, to have the ability to learn, to have the ability to memorize an infinite amount of data, because that's what characterizes medicine. An ever-changing data that changes all the time. I graduated from medical school 40 years ago. Actually, we had last week our 40-year reunion from medical school. I'm a graduate of the first class of Tel Aviv University Medical School, the second medical school in Israel. It opened in 1966. And what I learned in medical school, it's all mistake. All mistake. I mean, not the basic anatomy, not the basic physiology, although physiology also changed its face. So we are talking on a profession, and I understand the smiles. The smiles say, what's going on here? This guy wants to tell me that if I was treated 30 years ago by a physician, I got the wrong treatment. This is a topic for a different lecture. But there are answers to that, and the answer is no. But the medical knowledge, the medical data, the medical facts, the evidence in medicine of 40 years ago is worth nothing today, because diagnostic and therapeutic modalities. Yeah? X-ray, we don't call radiology departments radiology anymore, because most of the diagnostic modalities are not based anymore on X-rays. They are based on ultrasound, on PET scans, on MRIs, and not on radiology, not on X-ray technology. PET scan involves X-ray as well, but not MRI, not ultrasound, and not many other modalities. So we have to train physicians that we learn all through their life, like teachers, but we also have to sort the students so that they will have the ethics awareness, the behavior, the non-scholastic, non-cognitive skills that call for this profession where you have to spend your life at the bedside of a patient. So how do you select? How do you take an 18-year-old guy or a 21-year-old guy after the army, or even in a 4-year program, a 24 or 25-year-old guy that finished his bachelor degree, and assess his non-scholastic skills? Was he born with empathy? I would like to remind you that the definition of empathy, as opposed to sympathy, is the ability to go under the skin of the patient and feel what he feels. I can tell you that most of us are not born empathic. Definitely not deeply empathic. Can we change a congenital antipath to be a fully empathic person? The answer is absolutely no. So the task of medical educators is first and foremost to sort the students for medical school, those who are congenital empathics. And maybe you will teach me as teachers, how do you find that? A written test, an interview, a 1-hour interview, a 3-day workshop? Impossible. And we fail time and again on that. So Tel Aviv University and the Technion have a system called MORE, where they use the simulation center in Sheba Medical Center, and they ask the candidates to come, and they do group dynamics, and they sit together, and they talk to them, and then they have simulation, where in a one-way mirror rooms, they have to talk to actors, simulating clinical situations, ethical dilemmas, and they see their behavior. This is considered to be the best method today. Ben-Gurion University, that opened its gates over 30 years ago, and had a reputation for being able to attract better students in terms of their humane approach to patients. How do they do it? And actually I sat there yesterday on the admission committee and interviewed students. So again, they take those, the upper 1%, but they give more points to a 1-hour interview conducted by 2 interviewers. Usually one of them is a physician, one of them is a non-physician. Doesn't have to be a faculty member. He could be a representative of society, the deputy mayor of Be'er Sheva, a social worker for the community, a lawyer from the community, a judge from the community, who sits with a faculty member and interviews the youngster, and this youngster is brilliant. That's per definition, that's a prerequisite. And he has in a 1-hour interview to assess his integrity, his ability to be empathic, his communication skills, and they probably do better. For years, until Tel Aviv and the Technion Medical School started with their MORE program, and the Hebrew University only 5 years ago with what they call Mirkam, where the candidate passes from station to station, 8 stations, the OSCE system, and in each station he has 10 minutes to discuss a dilemma posed to him by one of the faculty members. Up until 5 years ago when they started that, when I finished a 3-hour round with graduates, new graduates of medical school, I could tell my colleagues if the student graduated from Ben-Gurion University or he graduated from the other universities. So much is the impact. 1 3-hour round, you could see the approach to the patient, the way he or she talks to the patient, listening or not listening to the patient, standing over the patient like this, or pulling a chair and forming the same eye level with the patient, and many, many other parameters. So sorting the students is one of the main issues. If you sort your students right, and the last part of the talk will be of sorting the teachers right, which is very simple. If you sort the students right, they will grow to be the right teachers. Because another characteristics of medical education is the role modeling. I'm not coming to say, and I'm sure that you will oppose me vehemently if I say that a teacher does not have to serve as a role model. I mean a teacher, a non-medical teacher, a teacher the type of teachers that you educate. Of course, you have to be a role model in the class. But I don't think that in any profession, a young physician or young medical students who go last in the rounds with a professor that goes and do a 3 or 4 hour round, seeing 15 or 20 patients in the rounds, talking to them, communicating with them and their families. If he does not serve as a role model in his patience and tolerance towards patients and families, in the way he communicates, in the way he demonstrates empathy, and we tend to be arrogant egomaniacs in our profession. I admit that. We definitely tend to be. And I think that this is the main issue that one has to fight in good medical education. Filter out the arrogant antipats. And filter out all those who do not become more modest with every year that elapses in our profession. The new graduate of a medical school, when he feels that he masters Harrison, Nelson, these are the 2 Bibles of internal medicine and pediatrics, and I can list the books in obstetrics and gynecology, in psychiatry, in surgery, and so on. So the new medical graduate, after all the tests that he has to take, he knows these books by heart, and he tends to be arrogant. He tends to be very proud about it. But if he is an attentive student, and if he listens to his patients and to his environment at large, he will become every year of his career more modest. Because every patient teaches us how much we don't know. You had these slides, what we know and what we don't know. In medical career, if you are attentive, if you are not a pampus ass, excuse me for the expression. If you are attentive, you become modest every year. And actually the aim of medical education is to sort teachers that will serve as role models in this respect. To conclude my presentation, there are a few other unique aspects to medical education. So whether it's a 4-year program or a 6-year program, it's divided into preclinical studies and clinical studies. In the preclinical, you teach the student the body of data. You start with chemistry and physics. Physics probably unnecessary in the regular profession, but traditionally first-year medical school, you learn this. And then you go to anatomy, one thing that did not change in many, many years, but from anatomy you move to physiology, the normal functioning of the body organs up to the subcellular level, and in molecular biology, that's where the major changes occur. So you learn physiology. Then you move from physiology to pathology. What happens when the organs and the cells of the body do not function properly? Then you have this merging topic between the preclinical studies and clinical studies that is called pathophysiology. You combine between the physiological aspects of the functioning of the body and the pathological aspects. And then the patient meets the patient for the first time. The student meets the patient for the first time. And this is a very critical moment in the career of the medical student, and it's a critical moment in our lives as medical educators. Because more than our difficulties to assess the non-cognitive skills of a candidate for medical school, it is even more difficult to predict who of those who master all this wide body of knowledge will be able to integrate and implement this body of data on the patient when he sees the patients. So the clinical skills are totally unpredictable. And I believe that this is the most difficult topic in medical education. I can see just in front of me the faces of students who had encyclopedic knowledge and had no idea how to integrate them on the patient. And this is, nobody found how to predict clinical skills at an early stage in medical school. So some of these students go to be researchers, Some of them leave medicine, some of them go to computers, because you don't have to relate to a computer as you have to relate to a patient. But this is one of the faults, how to predict the clinical skills. And I don't have time to speak about the student moving from a university campus to the hospital corridors, creating learning atmosphere in the hospital. I don't have time to talk about community-based learning. Most of medicine is not done in hospitals, it's done in the community, and we put too little emphasis on community-based teaching. I don't have time to talk about simulation centers. I will conclude by saying that the mission of medical educators is to supply society with humane, role modeling, empathic physicians. We can do it by proper sorting of the candidates and by proper sorting of the clinical teacher who will serve as role models. Thank you for your attention.